In this part of the test, you will hear a conversation between a physiotherapist and a new patient, Ms. Clara Davies, regarding her persistent shoulder pain. Now you have 30 seconds to look at the notes.
Good morning, Miss Davies. I'm Ben, the physiotherapist. Come in. I see Dr. Harris's paperwork flags you for chronic right-sided shoulder discomfort. That sounds rough.
Yes, thank you. I'm Clara. It's been absolutely maddening. My GP said it's probably something simple, but I'm really hoping you can give me a definitive diagnosis.
Based on Dr. Harris's preliminary assessment, and we'll confirm this now, the working diagnosis is often described as impingement syndrome. That means a structure is getting pinched. Tell me, when did you first notice any sort of issue?
Well, I'd say I've had stiffness for maybe 2 months, but the actual painful episodes only started hitting me about 6 weeks ago. It wasn't a traumatic event, no wrenching it or falling over a curb. I took a lovely trip to the coast last month, but the pain started after I got back home.
Understood. So no specific mechanism of injury, no heavy gardening, no awkward lift?
None at all. Honestly, I think it's just the accumulation of small strains, the repetitive nature of daily activities over time. My sister keeps telling me I'm too young for arthritis, but she had a knee replacement last year.
Right. Describe the quality of the sensation. Is it electrical, cramping, or perhaps a dull pressure?
It's not a sharp electrical shock, and it's certainly not superficial skin or irritation. It's a deep, persistent throb. The best way I can describe it is a dull, burning ache that seems to originate deep within the glenohumeral joint itself. It makes me want to rub it constantly.
Let's test function. What's the one thing that demands the most effort? Reaching for your coffee cup or perhaps lifting a light object overhead?
Lifting the kettle is fine actually, but it's the rotational movements, getting my arm into the sleeve. It's the most challenging daily task. It's putting on my coat or my seatbelt. That internal rotation is excruciating.
That difficulty with reaching across the body is key. We call that motion horizontal adduction. So typically, this type of pain is worst during overhead movements, anything past 90 degrees of flexion or abduction. Is that accurate?
Yes. Yes, anything I attempt to do when my hand goes above the level of my head is when it really catches.
Sleep disturbance is common with shoulder issues. How severely is it impacting your rest?
Dreadfully, I usually sleep on my stomach, but this forces me onto my left side. I end up waking up approximately 3 times each night, sometimes 4. And once I'm awake, it's hard to settle back down.
That must be exhausting. Tell me about work. You mentioned you're at a desk. Does the job exacerbate the symptoms?
I'm an accountant, so I'm constantly using the mouse and the 10 key. The pain is definitely most noticeable and worse after a long day of typing. I've tried a risk rest, but that hasn't changed the fundamental problem.
We can look at your setup later. Now, comorbidities. Are you managing any chronic conditions or is your general health pristine?
My general health is good. I do take tablets for my blood pressure. I manage mild hypertension. Nothing else, though. No asthma, no thyroid issues.
Noted. What anti-inflammatories or analgesics are you using?
My husband suggested I try aspirin, but I switched to something gentler. I'm currently using Tylenol, maybe 2 or 3 tablets a day. It offers temporary relief.
Okay, we'll document that as your current analgesic. And finally, hobbies. What activities do we need to temporarily sideline?
I play badminton on Fridays, and I was planning to start tennis lessons next month. Is swimming okay? I do breaststroke weekly.
We need to temporarily postpone that plan to start tennis. That overhead striking motion would be detrimental right now.
Swimming is generally fine, but no freestyle. Right. The initial focus won't be on strength, but on settling the system down. The primary goal for this first phase of treatment is to reduce the inflammation in the subacromial space around the joint. That will allow us to restore your passive range of motion.
Extract 2. Questions 13 to 24. You hear an orthopedic nurse specialist talking to a patient, Mr. Ryan O'Connell, during a follow-up appointment for Achilles tendonopathy. Now you have 30 seconds to look at the notes.
Good morning, Mr. O'Connell. I'm Lisa. We're reviewing your Achilles tendon issue today. The notes show a diagnosis of tendinopathy. Which leg is giving you trouble?
Oh, good morning. It's the left one. My right leg is absolutely fine, thankfully. My mother actually had trouble with her knees, but this is definitely tendon-related.
Right, the left side. When did this persistent pain start? Not the occasional niggle, but the chronic issue.
I'd say the minor discomfort was there maybe 3 months ago, but the full-blown debilitating pain has been with me since before Christmas. So it's approximately 4 months now. It feels like a very long time.
Any specific event or injury you can pinpoint that triggered it? A sudden run?
I play football on Sundays, but I haven't for months. I honestly think it came from wearing a pair of old, worn-out shoes. I mean, they had absolutely no support. So I blame the incorrect footwear. Not a specific injury, just the shoes I was wearing all day.
We see that frequently. On a visual analog scale, 10 being the worst imaginable pain, what level are you consistently at right now?
When I'm resting, it's a 1, maybe a 2. But when I get up, it shoots up. Yesterday, when I was trying to climb the stairs, it was about a 7. I'd say my constant daily level is around a 5. Sometimes a 6, but mostly a 5.
That level of pain severely limits activity. What is the one thing you find most difficult to do right now? Walking, standing, or climbing stairs?
It's definitely the walking downhill. I live on a slight incline, and every evening, that descent is just agonizing. Climbing stairs is tough, but going down is the absolute worst.
Understood. How is work? What do you do?
I'm a high school teacher, so I spend hours on my feet, giving lessons, walking the halls. I can still manage the teaching part, but I can no longer manage supervising sports day. The running and jumping are just impossible now. That's a huge commitment I've had to drop.
I see. Has this affected your choice of shoes?
It has, yes. I've thrown out the old ones, obviously. The only thing I can bear to wear now, even indoors, is my running trainers. I tried smart shoes for a wedding, but that lasted 10 minutes.
Right. We'll note the exclusive use of running trainers. What self-treatment measures have you tried? Did you use ice packs or anti-inflammatories?
I did use ice, but it didn't penetrate deep enough, I felt. I tried applying a heating pad for a few nights, thinking that might relax the muscle, but it actually made the morning stiffness worse. So I stopped that.
Noted. Any significant medical history we need to consider?
Well, I had my tonsils out as a kid, but nothing serious recently. Oh, wait, I was diagnosed with obstructive sleep apnea about 10 years ago. I still use a CPAP machine every night, but that's under control.
Sleep apnea, thank you. And any relevant family history?
My mother had knee issues. My father, he was a smoker, and he developed rheumatoid arthritis quite young. We think it was stress-related, but it was definitely RA.
Right. Now, your physiotherapy is key. What is the specific type of exercise your physio has emphasized? Is it general stretching?
No, he said stretching is secondary. The main focus is on the eccentric heel drops. It's exhausting, but he says that specific loading is what repairs the tendon.
Eccentric heel drops. Good. Our long-term goal for you is returning to full function. What pain level would you be satisfied with?
My current average is a 5. I would love to be pain-free, but I know that's not realistic. If I could manage a 2 or definitely below, that would feel like success. I could live with that.
That's a measurable goal, Mr. O'Connell. We'll aim for 2 or below.
Question 25. You hear a surgeon reminding the theater staff about the new count check procedure before closure. Now read the question.
Listen up, team. We've streamlined the closure checklist to save time, but there's one new non-negotiable step. Previously, the scrub nurse would verify the initial instrument count, and the circulating nurse would sign the final sheet. Now, the final instrument count must be verbally confirmed by both the scrub nurse and the surgeon before the dressing is applied. We've removed the circulating nurse from the final verification entirely. This dual confirmation is mandatory for all complex procedures from this.
Question 26. You hear a nurse handing over a patient, Mrs. Kwan, to a colleague. Now read the question.
Mrs. Kwan in 1C, post-op day 1. She's doing well, no pain at arrest. Her abdominal drain output is low, which is fine. The doctor's focus is on mobilization. She needs to walk the length of the corridor 4 times today. I checked her blood pressure this morning. It was slightly elevated, 145/90, but the crucial thing is the physical therapy. She refused the 8 a.m. walk citing fatigue, so the instruction is to ensure she completes her ambulation before the midday meal. Otherwise, she'll risk post-operative complications like DVT.
Question 27. You hear a geriatric nurse specialist advising staff on hydration monitoring for elderly residents. Now read the question.
When monitoring fluid balance in our elderly cohort, relying solely on intake-output charts can be misleading, particularly for those with existing cardiac issues. While skin turgor is often taught, it's not a reliable indicator in the very old. The most immediate and reliable objective sign of emerging dehydration is a subtle change in the patient's heart rate, showing tachycardia. This is much quicker to spot than sunken eyes or dry mucous membranes and allows for prompt intervention.
Question 28. You hear a pharmacist advising a patient about their new antibiotic prescription. Now read the question.
This antibiotic, doxycycline, is a highly effective medication used to treat a wide range of bacterial infections. You'll need to take one tablet twice a day for a total of 7 days to ensure the infection is properly cleared. However, there's a very important precaution you must follow during this treatment. Doxycycline can make your skin significantly more sensitive to sunlight, a condition known as photosensitivity. Because of this, you should always wear protective clothing, use a high SPF sunscreen, and wear sunglasses whenever you go outdoors, even on cloudy days. Most importantly, you must completely avoid using sunbeds or artificial tanning lamps during the entire course of treatment. Even brief exposure to ultraviolet UV light can trigger a severe phototoxic reaction, leading to redness, burning, and intense pain. Taking these precautions will help you stay safe while the medication does its job effectively.
Question 29. You hear a consultant dictating notes after a patient review for chronic low back pain. Now read the question.
Patient, Mr. Harper, 45, chronic lumbar pain. We've tried physical therapy and NSAIDs with limited success. He's asking about surgical options. The imaging reveals significant disc degeneration. I've reviewed the case and advised against surgery at this stage. Instead, I'm recommending a targeted injection. The key reason for rejecting surgery now is the lack of any demonstrable neurological deficit, such as foot drop or loss of reflexes. Until those objective clinical signs present, the patient's pain, while significant, remains manageable via conservative measures.
Question 30. You hear an epidemiologist discussing the success of a recent community vaccination drive. Now read the question.
The primary challenge wasn't public reluctance, which we managed through local outreach. Our main logistical hurdle was ensuring adequate cold chain storage capacity for the new mRNA vaccine. We had excellent vaccine supply and sufficient staff were trained, but the specialized ultra-low temperature freezers simply weren't available in all rural clinics. We had to lease additional units, which solved the problem. Without that temperature control, the vaccine would have been useless.
Part C. You will hear an excerpt from a health podcast featuring an interview with Dr. Elias Vance, a cognitive neuroscientist, discussing the nature of misophonia and its distinction from other sound disorders. You now have 90 seconds to look at the questions.
Dr. Vance, thank you for clarifying. Before we move ahead, there's one term that seems to confuse a lot of people: misophonia. Many still lump it together with general noise sensitivity. Could you unpack that difference for us?
That's a crucial distinction. There's a related condition called hyperacusis, where a person becomes hypersensitive to loudness. The overall decibel level literally hurts their ears. A fire alarm, crowded room, even a blender can feel unbearable. Misophonia, however, is fundamentally different. It's not about volume at all. Instead, it's an adverse emotional reaction to a very specific sound pattern, like chewing, sniffing, or the repetitive clicking of a pen. The patient isn't reacting to how loud the sound is, but to what the sound is. Even a whisper-level trigger can send them into distress.
So it's the pattern of sound, not the intensity. And when someone encounters one of these triggers, what does that reaction actually look like? Is it just irritation or mild frustration?
It's far beyond frustration. What we see is a full-blown fight or flight response, a surge of panic and anger that feels uncontrollable. Patients describe it as a wave of anxiety that hits instantly. Physiologically, their heart rate spikes, muscles tense, palms sweat, and their breathing quickens. It's not a conscious decision, and it's not a personality quirk. It's an automatic, reflexive reaction, deeply physical and profoundly distressing.
That sounds incredibly intense. Can you briefly explain what's currently understood about what's happening inside the brain to cause such a reflex?
Yes, this is where it gets fascinating. Our research shows that the primary auditory system, the part that detects sounds, is usually working perfectly fine. The problem appears to be an overconnectivity within the brain. Specifically, the emotional regulation areas, the limbic system, are too tightly wired to the sound processing regions. So, when a trigger noise occurs, instead of being processed as a neutral sound, it immediately sets off the brain's alarm system, producing an exaggerated emotional and physical response. It's like the brain's danger signal has been accidentally mapped onto harmless sounds.
That explains so much. But given that many of these triggers are everyday human noises, sniffing, breathing, eating, how does that play out in real life for patients?
Honestly, it can be devastating. Imagine being overwhelmed every time someone next to you chews. People start avoiding normal environments, family dinners, classrooms, offices. They'll eat alone, skip social gatherings, even leave jobs to escape constant exposure. While that avoidance brings temporary relief, it often leads to profound social isolation. The silence they achieve comes at the cost of relationships, community, and often self-worth.
That's heartbreaking. So when patients finally seek help, how do clinicians begin treating something that seems so specific and so neurologically rooted?
The cornerstone treatment is a hybrid approach combining cognitive behavioral therapy, CBT, with sound therapy. One of the main techniques we use is counter-conditioning. Instead of forcing the person to get used to the sound, which often backfires, we help them associate it with a positive or calming context. For example, the patient might listen to their trigger sound while engaging in relaxation, exercises, deep breathing, or a favorite hobby. Over time, this process helps the brain relabel the sound, dismantling the automatic link between the noise and distress.
That sounds like slow but hopeful work. As research progresses, what's the next major milestone the scientific community needs to reach in order to truly advance treatment for misophonia?
The critical next step is standardization. Right now, every clinic defines and diagnoses misophonia a bit differently, which makes comparing data or treatment outcomes difficult. While developing new medications is a tempting avenue, our top priority should be to identify consistent neurobiological markers, physical signatures visible in brain imaging. Once we can pinpoint and visualize the condition, literally see it in the brain, we'll have the foundation to create global diagnostic criteria. That will finally validate misophonia as a legitimate, measurable disorder and lead to more uniform, effective treatment protocols worldwide.
Part C. Excerpt 2.
You will hear an excerpt from a medical podcast featuring an interview with Dr. Hannah Cole, a consultant gynecologist, discussing the persistent challenges in diagnosing and managing endometriosis. You now have 90 seconds to look at the questions.
Dr. Cole, thank you for joining us. The diagnostic delay for endometriosis is still averaging 7 to 10 years globally. Why is this chronic issue so persistently missed by primary care?
It's complex. A part of it is the cyclical nature of the pain, which patients are often told is normal. But from a medical perspective, the greatest hurdle is the training. The condition presents so variably. Clinicians are primarily trained to identify acute surgical emergencies like appendicitis or ectopic pregnancy. Unfortunately, the vast majority of clinical training frequently emphasizes acute conditions over chronic ones, meaning symptoms of chronic disease, like deep pelvic pain and dyspareunia, are often secondary. And that's the main driver of the delay, not necessarily patients being silent. Many times it's just diagnosed as IBS because the symptoms overlap.
For decades, the gold standard for diagnosis was surgical laparoscopy. Has that approach changed?
It has, thankfully. Historically, we relied far too heavily on laparoscopy. If you had symptoms, you got surgery. If you didn't have symptoms, you got investigated for something else. That approach was flawed because it definitely led to an unnecessary increase in the frequency of invasive procedures. Now, we use imaging like advanced ultrasound and MRI far more frequently to diagnose clinically, reserving surgery for severe cases or when pain is unresponsive to medical management. We're moving away from the look-see method.
The pain is often described as crippling. What is the actual pathophysiology behind it? Is it just the physical presence of the lesions?
It's not the implants themselves that cause the continuous pain. The implants, wherever they are, on the ovaries, ligaments, or bowel, shed and bleed during menstruation, which creates local irritation. The real problem is that the body launches a massive immune response to this foreign tissue. So the chronic pelvic pain is primarily caused by the continuous inflammation of the immune system to the implants. This inflammation then sensitizes the surrounding nerves, which is why the pain is so constant, even outside the menstrual window. Adhesions are a complication, but the underlying driver is inflammation.
If you use hormonal treatments like GnRH agonists, what is the key mechanism you're trying to achieve?
Medications like GnRH agonists or continuous progesterone aren't painkillers. Their job is to create a hormone environment where the disease cannot thrive. They aim to reduce estrogen levels significantly. The simplest way to put it is that the goal is to induce a state similar to menopause, to halt the cyclical effect of estrogen and progesterone on those rogue cells. We aren't trying to magically eradicate the lesions, though they may shrink. We're essentially starving them of their hormonal fuel.
For a nurse or a GP seeing a young woman with severe period pain, what simple change in assessment should they make to improve outcomes?
Stop asking, is your pain normal? Because she's probably been told it is. And don't just focus on the type of pain or where it hurts, although mapping is useful. The most meaningful data for endometriosis screening is subjective but powerful. The best thing is to quantify the impact of the pain on the patient's quality of life. Ask, on how many days per month does this pain prevent you from going to work or socializing or exercising? That shifts the focus from normal pain to functional disability.
Finally, what does best practice look like for long-term care?
It must be holistic. Surgery has a role, medical suppression has a role, and managing the psychological burden is essential. But the key to success and sustained improvement is a collaborative framework. Comprehensive care for endometriosis must involve a multidisciplinary approach involving pain specialists and physiotherapists to address the pelvic floor muscle tension and central nervous system sensitization that inevitably develops. You can't just operate and give a pill. You need the whole team.